The purpose of this also very important guideline was to assist physicians involved in treatment of graft infections to select its best management strategy in different scenarios and to promote a standard of care according to specialists in the field. Again, we had a similar writing committee, including experts from various countries, and we also included, because of the multidisciplinary approach here, the European Association of Nuclear Medicine and also a French group studying the impact of infections on prosthesis. This year was the writing group containing members of the European Society for Vascular Surgery and others outside the society. We referred here to the ESC grading system, as we do for all other guidelines published from the ESVS. And again, we had a thorough review process, including the guidelines committee and also some external reviewers, having 3 complete rounds after finally finalizing the draft of this paper here. The second meeting was in September 10, 2018, and again in June 2019 the process was about to be finalized. The final guidelines include 53 recommendations with an overall scarce high-level evidence here. So this opens the doors for future research, and there are just not enough randomized clinical trials, mostly retrospective studies with only very limited amounts of patients, which finally counts for this low level of evidence. As you can see here in this summary, we have 39 recommendations with a level C of evidence and 17 recommendations with a class 2B recommendation. Coming first to the appropriate classification for a vascular graft infection. There were 3 different classification models studied, including Szilagyi, the Bund classification, and finally the MAGIC classification. And this writing group finally decided to apply mainly to this MAGIC classification, because the advantage here is that it includes, besides clinical surgical aspects, also radiologic aspects and laboratory aspects, including the organisms, the virulence of the organisms, and also blood cultures and inflammatory levels within the organism and the blood. So this was the recommendation that once a vascular graft infection is suspected, exhaustive evaluation of the clinical status should be performed, signs of infection and patient comorbidities according to the MAGIC criteria is recommended, a class 1 recommendation. Diagnostics should include as a golden standard positive cultures in terms of punctures or even by removing of the graft. In addition to this, different imaging modalities are possible to use, including ultrasound, CTA, FTG, PET scan, or SPECT CT scans. Here we can see such an aneurysm, pseudoaneurysm, including air, perigraft, soft tissue, focal bowel thickening, and discontinuity of the aneurysmal wrap. So the recommendation concerning the CT angiography is for suspected vascular graft infections. CT angiography is recommended as the first-line diagnostic modality, and patients suspected for graft infection, if computed tomography angiography is contraindicated, just then the use of MRI may be considered. PET scans, FDG PET scans are very sensitive and are supposed to be used in all cases where a normal CT angiography is not very conclusive. So with this high sensitivity and specificity, although no final consensus was found here, the recommendation was that for these patients with non-convincing findings on CT angiography, the use of FTG positron emission tomography combined with low-dose computed tomography is recommended as an additional imaging modality to improve diagnostic accuracy. So not a first-line option, but a second-line diagnostic tool. Then the guideline was diverted into several anatomic regions, starting with supra-aortic trunks with a very low overall incidence of infection. With these typical kinds of presentations, the diagnostic signs were included in the recommendation that when a patch corrugation after carotid endarterectomy with patchplasty is found during endarterectomy follow-up in ultrasonography, further investigations may be considered to exclude a vascular graft infection. And concerning treatment, there were several recommendations, including conservative treatment, including antimicrobial therapy without reconstruction. May be considered for patients unfit for surgery, and just in an emergency setting with active bleeding in patients, a combined endovascular first and then surgical approach may be considered. This is mainly based on a study published by Anders van Heijnen from Uppsala. And then the endovac technique may be considered as a treatment option in selected patients when neither total removal of infected material nor the unusual conservative VAC therapy are considered feasible or safe. Additional treatment options for these patients include that total removal of the infected material followed by reconstruction with autologous material is recommended, level 1, class 1, level C recommendation. And so now coming to the abdominal part of the aorta, excluding the thoraco and the thoraco-abdominal part just for sake of time, percutaneous drainage may be useful to reduce the amount of bacteriological burden before definite treatment. And in another recommendations, in patients fit for surgery, complete excision of all graft material and infected tissue is recommended for definite treatment, and in situ reconstruction with autologous vein should be considered as a class 2A recommendation. Patients with an abdominal aortic vascular graft infection, either cryopreserved grafts, silver-coated grafts, rifampicin-bonded polyester grafts, or bovine pericardium should be considered as alternative solutions. There is no clear evidence in favor for the one or the other therapy. Partial excision is also an option for all these patients where the infection is only limited and the remaining material is well incorporated. And finally, for patients with abdominal aortic vascular graft infection and a large abscess or multi-resident organisms, an extra anatomical reconstruction may be considered. That points out to the importance of this magic scale of diagnosis. And after all, a lifelong imaging follow-up is recommended after in situ reconstruction with cryopreserved allografts in order to detect allograft degeneration. Again, a class 1 recommendation. I will now go over to the peripheral arteries here for the sake of time. Here again, in situ reconstruction with autologous vein reconstruction is recommended with a high class recommendation here. If the infection is only limited to a part of the graft and in patients unfit for surgery, local irrigation and or negative pressure wound therapy may be considered as a definite treatment option in these patients. And in addition, in patients with infection, in situ reconstruction with cryopreserved allografts should be considered as an alternative treatment if it is likely to lead to limb ischemia or after removal of this graft, in case autologous vein is not available, and patients finally with a large tissue defect following resection of infected tissue, muscle or musculocutaneous flaps should be considered to promote groin healing following graft removal and debridement with or without vascular reconstruction. Thank you very much for your attention.